You know, usually when we talk about a medical diagnosis, there's this expectation of precision, like engineering.
Right. It's binary.
Yeah, exactly. You break your arm, the x-ray shows that jagged white line, and the doctor just points at it and says, there it is, broken.
It's clean. I mean, the human mind naturally craves that kind of visual confirmation. We like things to be visible.
We want it to be easily categorized,
Mm.
and most importantly, we want a clear mechanical fix.
Absolutely. But then you step into the world of neurodevelopment.
And genetics.
Yeah, and suddenly that X-ray machine is entirely useless. We're looking at a diagnostic landscape that is completely murky.
Completely. I mean, we are talking about a single missing molecule out of hundreds, creating a chain reaction that breaks the body's most fundamental software before a child even takes their first breath. So, welcome to another deep dive for the PURA Syndrome podcast.
We are completely decoding a condition known as PURA syndrome today.
And we are talking directly to you, especially if you are a parent or a carer of a child with this diagnosis.
Which is a diagnosis so incredibly rare and, well, so recently discovered that just 10 years ago it didn't even have a name in the medical literature.
That is wild to me.
It really is. If you took a child showing these exact symptoms to the best neurologists in the world in, say, 2013, they would likely have no idea what to call it, let alone how to treat it.
Which is just a terrifying prospect for any parent trying to navigate those waters.
Yeah.
To not even have a name for the storm you're fighting.
Definitely. But today, we have a massive stack of sources illuminating this condition for our deep dive.
We do. We're pulling from clinical guidelines, deep genetic research papers, and some incredible patient foundation data.
Yeah, specifically from the PRA Syndrome Foundation and PRA Foundation Australia.
Right. And we also have detailed therapeutic overviews from the Napa Center, plus some fascinating case studies looking at everything from ketogenic diets to complex scoliosis surgery.
It is a literal mountain of information. But when you lay it all out, it paints a remarkably clear picture of a condition that affects almost every single system in the human body.
So our mission for this deep dive is to take you all the way back to the molecular origins. You know, that tiny genetic typo where it all begins.
And from there, we'll explore the immediate, terrifying challenges at birth.
Right, and then we're going to dive really deeply into the therapies. We have a major focus today on occupational therapy.
Which is crucial. We're looking at those small gains in daily living, like hand-eye coordination and fine motor skills.
Exactly. Giving you practical tips for helping your child learn to reach, grasp, and eventually feed themselves. And then finally, we'll look at the cutting-edge research mapping out a future of targeted treatments.
And I think the paradox at the heart of PURA syndrome is what makes this so compelling.
How do you mean?
Well, we are talking about a microscopic genetic deletion that causes profound physical and developmental hurdles. Yet, it leaves these individuals with surprisingly high social intelligence.
Oh, yeah. The sources kept mentioning their deep capacity for affection.
Right. And an incredibly high receptive understanding of the world around them.
It's a journey of absolute resilience. But if we want to understand how PURA syndrome affects a child's daily life, we really have to start at the blueprint.
We have to look at the genetic code, where the foundation is actually poured.
Yeah, and how scientists finally managed to connect the dots just over a decade ago.
It was an absolute mystery for a long time. I mean, for decades, pediatricians and geneticists were seeing children presenting with this severe, unexplained developmental delay.
And remarkably low muscle tone, right?
Huh.
Plus those complex seizures.
Exactly. But because it mimics so many other things, these children were often misdiagnosed, or they were just labeled as having a generic, undiagnosed developmental disorder.
Until October 2014, that's when the pieces finally fell into place.
Yeah. In the grand timeline of medical science, October 2014 is practically yesterday morning.
It's incredibly recent.
That month marked the publication of the very first clinical papers recognizing PURA syndrome as a distinct, isolated condition.
And it was a massive international effort, right? I saw Dr. David Hunt in the UK and Dr. Seema Lalani in the US mentioned in the sources.
Yes, they were pivotal. And we've just passed the 10th anniversary of this breakthrough.
10 years of having a name for something that has undoubtedly existed hidden in the background for all of human history.
It's humbling to think about.
So let's get into the actual genetics of what they found. Where's the typo?
They located the issue on chromosome 5. To give you the exact address, it's at a locus known as 5q31.3.
Okay, so humans have 23 pairs of chromosomes.
Right. And on the long arm of the fifth pair, there is a gene called PURA.
Spelled P-U-R-A.
Correct. And the disease is caused by what geneticists refer to as a heterozygous pathogenic variant.
Let's translate that for anyone who hasn't taken a biology class in a while.
Fair enough.
Heterozygous basically means you have two copies of the gene, right? One inherited from your mother and one from your father.
Yes, but only one of them has the mutation. You only need one copy of the PRA gene to be altered or missing to develop the entire syndrome.
Wow. Just one.
Yeah. The medical term for this is haploinsufficiency. Your body has one perfectly good working copy of the gene, but one good copy simply isn't enough.
It can't produce the total volume of protein the body needs to function normally.
Exactly. And a really crucial point here is that this is almost always a de novo mutation.
Meaning it's spontaneous, the parent's genes are completely fine.
Right, it wasn't inherited at all.
It's just a random, unpredictable typo that occurred during the very early stages of cellular division when the embryo was forming.
A spontaneous copying error, yes. And to understand why this specific copying error is so devastating, we have to look at the unique architecture of the PRA gene itself.
The sources called it a single exon gene.
Yes, a single exon gene, which is structurally pretty rare.
Let's try to visualize this because standard genetics can be kind of abstract.
Yeah.
Most genes are made up of exons and introns.
Right.
If we think of a gene like a movie being filmed, you shoot different scenes. Those are the exons. And the stuff you don't need, the flubbed lines, the background noise, the long pauses.
Those are the introns. That's a great baseline for standard genetic transcription.
The cellular machinery acts like a film editor, right?
Exactly. It cuts out the bad takes, the introns, and splices the good scenes together into a cohesive final product.
So if there's a minor mistake in one scene, sometimes the cellular editor can splice around it or use a slightly different take.
But a single exon gene isn't edited.
It's shot in a single, continuous, unbroken take. No cuts, no editing room.
That completely captures the vulnerability of the structure. I mean, if an actor coughs in minute 45 of a single-take movie, you can't just cut away to a different angle.
The entire sequence is just ruined.
Yes. Because it lacks those internal divisions, the sequence integrity of the PURA gene is absolute. It has literally zero margin for error.
So if there's a typo in that one continuous sequence, the reading of the gene is fundamentally broken.
Completely broken.
And this gene has a very specific job, right? It provides the instructions for making a protein called pure alpha.
Yes, usually written as PUR with the Greek letter alpha. And PUR alpha is a protein made up of exactly 322 amino acids linked together in a very specific chain.
Okay, 322 links.
Right. And when geneticists look at the mutations that cause PURA syndrome, they actually find a mutational hotspot.
Like a specific area that breaks most often.
Exactly. The most common variant identified across the globe is known as P233del.
P233del. So breaking that down, it means a deletion at the 233rd position of that 322 linked chain.
It means that just one single amino acid of phenylalanine residue is deleted from the sequence.
There's one microscopic missing link out of 322.
But because of where that missing link is located, the entire three-dimensional structure of the protein just collapses.
Because proteins work like keys fitting into locks, right? Their physical shape is their function.
Exactly. This specific deletion ruins a section called PUR repeat 3, which is the part of the protein that acts like a claw to physically bind to DNA and RNA.
So without that claw shape, the protein is entirely useless. It just floats there, unable to grab onto anything.
One missing molecule out of 322. It is mind-boggling how fragile human biology can be.
It really is. And looking at the sources, there are other variants too. There's one called PMET157-ARGR, which is a missense mutation.
Right, where one amino acid isn't missing, but it's swapped for the wrong one.
Which still ruins the shape. And then there are patients who have entire 5q31.3 microdeletions.
Where they are missing the whole PRA gene.
Yeah, and even some neighboring genes on the chromosome, like one called NRG2.
And those individuals with the larger microdeletions tend to have a more severe clinical presentation across the board.
Because they're losing more than just pure alpha.
Right. They're losing the synergistic effects of multiple genes in that neighborhood working together. But whether it's a deletion of the whole gene neighborhood or just that one single missing phenylalanine, the resulting syndrome is incredibly rare.
How rare are we talking?
As of late 2024, the global registries show only about 706 to 800 confirmed cases across 60 countries.
800 people in the entire world.
The estimated incidence is something like 1 in 1 million. It is the absolute definition of an ultra-rare disease.
Though, I guess we have to assume that as whole exome genetic sequencing becomes more standard globally, that number will climb.
Absolutely. As older, undiagnosed individuals finally get accurate answers, we'll see those numbers go up.
I have to pause here and ask the obvious question. Why this specific protein?
What do you mean?
Well, we have tens of thousands of proteins in our bodies. Why is pure alpha so vital that a single typo, a single missing amino acid, causes a catastrophic cascade of effects across the entire body? What does this protein actually do?
Well, what's fascinating here is that pure alpha isn't just a structural building block like collagen or keratin. It is a master regulator.
Like a project manager.
Exactly. A project manager operating at the very highest levels of cellular control. It regulates DNA replication, telling the cell when to copy itself. It regulates transcription, turning DNA into actionable RNA.
Okay, but what about its impact on the brain? That seems to be the core issue.
Right. Its most critical job, the one that really explains the profound neurological impact of PURA syndrome, happens deep inside the brain.
Take us down to the cellular level in the brain. What is the project manager doing there?
In a developing brain, pure alpha acts as a high-priority transport vehicle. It physically binds to mRNA, the messenger molecules that carry the blueprints for new cellular machinery.
Okay, it grabs the blueprints. Then what?
It transports them out of the center of the neuron, traveling all the way down the long arms of the cell into the dendrites.
The dendrites being those branch-like structures that reach out to connect and communicate with other neurons.
Exactly. The dendrites are where synapses are formed. And in order for a synapse to change, to adapt, to form a memory, or to learn a new motor skill, the cell needs to build new proteins right there at the connection point.
Far away from the nucleus.
Right. Pure alpha delivers the blueprints to the construction site. Without pure alpha, those blueprints never leave the nucleus.
So the construction site just shuts down.
Entirely. The dendrites cannot mature. The synaptic connections fail to form or stabilize properly.
This single protein is foundational for memory, for learning, and for what we call synaptic plasticity.
So we are talking about a brain that is literally struggling to wire itself from the moment the fetal nervous system begins to develop.
Because the project manager responsible for delivering the blueprints is missing. The infrastructure is fundamentally compromised.
And because this project manager is missing from the very genesis of brain development, the effects of PURA syndrome don't wait to appear.
They don't suddenly emerge in late childhood.
No, the consequences are immediate and severe the very second the child is born.
If Pure Alpha's main job is delivering blueprints for the brain to build itself, what happens when those blueprints never arrive? We don't have to wait years to find out.
Right, because the brain controls basic survival software right out of the gate.
So the clinical presentation at birth is highly specific. The literature calls it a neonatal triad. 3 major symptoms that hit simultaneously.
Turning the delivery room or the NICU into a critical care situation instantly.
Let's walk through that triad. What's the first pillar?
The first pillar is severe hypotonia.
Which refers to profoundly low muscle tone.
Yes. In the medical field, it is often colloquially referred to as floppy baby syndrome.
Meaning these infants lack the baseline resting muscle tension needed to hold their limbs up.
Or to maintain any sort of posture, or even to move their arms and legs effectively against the pull of gravity.
But it's crucial to understand the source of this weakness. The literature heavily emphasizes that this is central in origin. It's brain-based.
Correct. It is not a peripheral muscle disease like muscular dystrophy.
The muscles themselves are physically fine, right?
The muscles are entirely intact. They are perfectly ready to work. But the brain is failing to send the continuous low-level electrical signals required to maintain normal resting muscle tone.
So the hardware is in perfect condition, but the software running it is completely offline.
Exactly.
Now, here's where it gets really interesting. I was reading through the clinical characteristics, and there is a massive clinical clue hidden in this hypotonia.
Ah, the reflexes.
Yes. Despite the fact that these infants are so weak they can barely move, they actually retain their deep tendon reflexes.
It's a huge diagnostic indicator.
So, if a neurologist taps their knee with that little rubber hammer, their leg still kicks perfectly. I had to read that twice. If their muscles are so weak they can't fight gravity, how do they still have a knee-jerk reflex?
You hit on the exact paradox that tells the neurologist exactly what is wrong. Think about what a deep tendon reflex actually is. It's a localized, closed-loop circuit.
Okay, explain how that circuit works.
The tap on the knee stretches the tendon, which sends a rapid signal up the sensory nerve to the spinal cord. And the spinal cord doesn't ask the brain for permission.
It just reacts.
Instantly. It sends a signal right back down the motor nerve to tell the muscle to contract. It is an emergency response system that entirely bypasses the higher order processing of the brain.
So the reflex proves that the local circuit is perfectly intact.
It proves that the peripheral wiring, the nerves connecting the spinal cord to the muscle, and the muscle tissue itself works flawlessly.
So when a doctor sees a floppy baby whose leg still kicks when tapped, it immediately isolates the problem.
It tells them the issue must be higher up, in the central command center of the brain.
This is how doctors differentiate PURA syndrome from peripheral disorders like spinal muscular atrophy or SMA.
Right. In a baby with SMA, the peripheral nerves are dying, so those deep tendon reflexes are completely absent.
That distinction changes the entire diagnostic path. So profound central hypotonia is the first part of the triad. What's the second part?
The second part is respiratory insufficiency. And reading the accounts of this, it sounds absolutely terrifying for a new parent trying to bring their baby home.
The sources say over 50% of infants with PURA syndrome experience recurrent apnea.
Which is the medical term for simply ceasing to breathe.
And this happens to these infants in two very distinct, equally dangerous ways, right? Central apnea and obstructive apnea.
Yes. Let's start with central apnea, which ties right back to that broken central command center.
Okay, the software failure.
Exactly. In a healthy brain, a region deep in the brainstem called the reticular activating system sends a continuous, rhythmic, involuntary signal to the diaphragm and the lungs.
It just says inhale, exhale, inhale, exhale.
Totally automatic. You don't have to think about it.
Yeah.
But in an infant with PURA syndrome, because PUR-alpha is highly expressed in the brainstem during development, that autonomic signaling network is deeply dysfunctional.
The brain literally forgets to send the signal.
There is zero drive to inhale. The lungs are waiting for a command that just never arrives.
And then compounding that, you have obstructive apnea, which is a mechanical failure.
A mechanical failure driven by the hypotonia. Because the muscle tone is so low all over the entire body, the muscles in the throat, the pharynx, and the upper airway are also incredibly floppy.
They lack rigidity.
When the baby relaxes or enters a sleep cycle, those airway muscles simply collapse under their own weight. They physically block the flow of air, acting like a kink in a garden hose.
So they're battling both the software failing to send the breath signal and the hardware collapsing and blocking the path, even if the signal gets through.
It's a dual threat.
The clinical guidelines note that many of these newborns require CPAP machines, continuous positive airway pressure, to physically force the airway open with a constant stream of air.
Some even require full mechanical ventilation and supplemental oxygen.
But the literature does offer a glimmer of hope on this specific symptom, doesn't it?
It does. While the neonatal respiratory distress is acute, highly stressful, and often life-threatening, it frequently improves or even resolves entirely after the child turns 1 year old.
Oh, wow. Why is that?
The brainstem seems to slowly mature enough, and the airway muscles eventually gain just enough baseline tone that the immediate life-threatening crisis passes.
Though it's important to note that many of these children will still require sleep studies and nighttime monitoring for years.
Definitely. So that's hypotonia and apnea. The third pillar of the neonatal triad is feeding difficulties, specifically a condition called dysphagia.
Over 80% of infants with PURA syndrome struggle profoundly with feeding.
To extract milk from a breast or a bottle safely, a newborn has to master an incredibly complex, highly coordinated sequence of movements. Suck, swallow, breathe.
It is something we completely take for granted as an instinctual reflex, but mechanically, it's a massive undertaking.
It requires the precise, split-second timing of dozens of muscles in the face, the jaw, the tongue, the pharynx, and the chest, all coordinated by multiple cranial nerves.
If an infant has severe oromotor hypotonia low tone in the mouth and throat, and the brainstem is already struggling to coordinate a basic breathing rhythm, that suck-swallow-breathe cycle completely falls apart.
And the risk isn't just that the baby won't gain weight. The immediate risk is aspiration.
Which means fluid getting into the lungs.
Exactly. If the swallowing mechanism is uncoordinated, the epiglottis fails to protect the airway. Milk or formula slips past the vocal cords and goes straight down the trachea into the lungs instead of down the esophagus into the stomach.
And that causes aspiration pneumonia.
Which can be fatal in an already compromised infant.
To bypass this, many infants require temporary nasogastric tubes. An NG tube passed down through the nose, past the throat, directly into the stomach to ensure they get calories safely.
And if the dysphagia proves to be chronic and the swallow study shows continuous aspiration, the surgical team will place a permanent gastrostomy tube, or G-tube, directly through the abdomen into the stomach.
Hypotonia, apnea, dysphagia, a nervous system overwhelmed from day one. There are a couple of other really unique early signs mentioned in the clinical history data that speak to this autonomic dysfunction.
Like the hiccups.
Yes. Mothers frequently report that when they were pregnant, the baby had excessive, vigorous hiccups in utero, and those hiccups persist constantly into early infancy.
That is another direct manifestation of erratic brainstem signaling. A hiccup is an involuntary spasm of the diaphragm. The nervous system is misfiring, sending chaotic electrical bursts down the phrenic nerve.
The newborns also experience profound hypersomnolence, which means excessive, unarousable sleepiness. Alongside hypothermia, an inability to regulate their core body temperature.
Wakefulness and thermoregulation are both controlled by the autonomic nervous system, specifically centers in the brainstem and the hypothalamus.
So without PURA establishing those neural pathways, the internal thermostat and the biological alarm clock of the brain are broken.
The infant struggles to rouse themselves to engage with the world, and they cannot shiver or adjust their vascular system to keep themselves warm.
It's an overwhelming cascade of challenges right out of the gate. But human biology is resilient. And as these children survive this acute neonatal crisis and grow into toddlers, the focus for you, the parents, and the medical team naturally shifts.
It transitions from pure minute-by-minute survival to the long-term reality of neurodevelopment.
We move from the NICU into the therapy room, focusing on daily life, motor skills, and the immense communication gap.
This transition is where the reality of PURA as a lifelong neurodevelopmental disorder sets in. The developmental gap between a child with PURA and a neurotypical child widens significantly as time goes on, particularly when we look at gross and fine motor milestones.
The clinical guidelines, especially the deep dive we have from the Napa Center, emphasize how severely delayed gross motor skills are. Most children with PURA never walk independently.
And those who do eventually achieve it usually do so somewhere between the ages of 3 and 10.
And when they do walk, it's described as a very wide-based, unsteady gait.
Think about the physical foundation they are trying to build upon. They're starting with profound central hypotonia. Their muscles are fighting a relentless, exhausting uphill battle against gravity every single day.
Just learning to hold their head up or sit without falling over requires immense concentration and physical effort.
Which brings us to a major focus of our deep dive today. Specifically for you, the parents and carers listening who live this every day. We are talking about the immense critical role of occupational therapy and physical therapy.
The literature stresses that this isn't just about trying to force a child to hit a standardized milestone like walking. It's about what therapists call small gains in daily living.
Yes, the focus on hand-eye coordination and fine motor skills is absolutely paramount.
It's about intensive OT, focusing on upper limb strength and those fine motor skills that eventually grant a measure of independence.
When we analyze the biomechanics of a child with PURA syndrome, we have to look at energy allocation. When your core is hypotonic, your brain expends massive amounts of neurological energy and muscular effort just trying to keep your torso upright in a chair.
Right, just sitting as a workout.
That continuous effort leaves very little bandwidth and very little physical stability for distal movements.
Distal meaning the faraway parts, the hands and fingers.
Exactly, the fine, precise, highly coordinated movements of the hands.
I want to spend some real time exploring this, because for a family, this is the day-to-day reality. Watching your child try to learn how to reach for a toy, how to grasp it, and eventually the monumental goal of learning how to feed themselves.
It is a monumental goal. When you actually break down the physics and the neurology of feeding yourself, the amount of coordination it requires is staggering.
It is an incredibly complex sequence that we execute thoughtlessly. Let's break down the act of reaching for a specialized adaptive spoon.
First, the child's brain has to visually locate the object and calculate its distance in three-dimensional space. Then, the brain must send a signal to stabilize the shoulder joint, which acts as the anchor.
Which we know is difficult because of the hypotonia.
Right. Then the triceps must extend the elbow against the constant resistance of hypotonia, pushing the arm forward.
And that's just getting the hand to the general vicinity of the spoon.
Exactly. Then comes the grasp. Grasping requires the intricate, fine motor coordination of the intrinsic muscles of the hand and the flexor tendons of the fingers.
The brain has to adjust the grip force perfectly. Grip too loosely and they drop the spoon, grip too tightly and they can't maneuver it.
And finally, they have to navigate that loaded spoon back to their mouth without spilling. To do that without staring directly at the spoon the entire time, the brain relies on proprioception.
Proprioception, the body's internal GPS system.
It's the nervous system's ability to sense the position and movement of our joints in space. But in PURA syndrome, because of the low muscle tone, the receptors in the joints and muscles aren't sending strong, clear signals back to the brain.
The internal GPS is fuzzy.
So it's a monumental cognitive and physical task.
And this is where the practical genius of occupational therapy really shines. The whole philosophy is about breaking that monumental task down into tiny, achievable micro steps and altering the environment so the child can succeed.
Yes.
So for a parent listening, what does that actually look like in practice? How do you teach a child to feed themselves when their internal GPS is fuzzy?
It fundamentally starts with posture and positioning. Before you can ever expect a child with PURA to use their hands effectively, their core must be completely artificially supported.
An occupational therapist will start by ensuring the child is seated in a highly customized chair, right?
With rigid lateral supports hugging their ribs, a pelvic strap to keep their hips back, and perhaps a slight recline. If the trunk is securely stabilized by the chair, the brain no longer has to panic about falling over.
The arms are finally free to move. It's the old structural adage. You can't fire a cannon from a canoe.
A perfect analogy. The core is the canoe. You have to put it on solid ground.
Once the core is stabilized, OT focuses heavily on hand-eye coordination through targeted play.
An OT might start by suspending toys right in the child's midline, so they don't have to fight gravity as much to reach them. They use hand-over-hand assistance, physically guiding the child's hand to grasp an object,
Helping the child's brain feel what a successful motor pattern feels like.
over time, as pathways form, the therapist introduces adaptive equipment.
This is where we see things like specialized spoons with thick, built-up, heavily weighted handles, or bowls with strong suction cups on the bottom so they don't slide away.
And the weighted spoon isn't just about making it easier to hold, it's a neurological tool.
Going back to that fuzzy proprioception.
Exactly. By making the spoon significantly heavier, you increase the mechanical drag on the muscles and joints. That heavy spoon acts as a stronger sensory signal, cutting through the neurological static.
Giving the brain more definitive feedback about exactly where the hand is in space.
It is essentially sensory hacking.
Sensory hacking to help the brain map the movement. The ultimate goal is to move from a state of total reliance on caregivers for every single calorie, to perhaps helping guide the spoon, to eventually, for some patients, achieving independent self-feeding.
These are the small gains in daily living that drastically, fundamentally alter the trajectory of their lives and their sense of agency.
Agency is the ultimate goal of all these therapies, giving the child control over their environment.
And agency is the perfect bridge into the other major hurdle these children face, which is communication.
The literature refers to it as the receptive-expressive discrepancy. This is highlighted in every single piece of literature we reviewed as a defining hallmark of PURA syndrome.
It is arguably the most recognizable cognitive feature of the syndrome. When we look at the expressive side, the vast majority of patients are nonverbal or non-speaking.
Some may achieve a few single words or perhaps very short, highly practiced phrases, but fluid, conversational spoken language is exceedingly rare.
However, their receptive language, their ability to hear, process, and completely understand complex commands, humor, and conversations happening around them is incredibly high.
So what does this all mean for a parent? Put yourself in the shoes of a child with this condition. You have a brilliant, active mind. You have high level of understanding.
You know what you want to say, you know what hurts, you know what's funny.
But you are trapped behind an insurmountable physical communication barrier. It must be incredibly isolating. It's like being placed behind thick, soundproof glass.
You can see everything, you understand everything, but no matter how hard you scream, no one on the outside can hear you.
How do we even measure progress if they can't speak?
If we connect this to the bigger picture, it forces therapists and parents to completely redefine what communication looks like. Progress isn't measured in standard milestones. Traditional speech therapy remains vital, of course.
It helps with dysarthria, which is the slurred, imprecise speech caused by poor muscle control in the mouth.
And it continues to strengthen the oral motor coordination needed for the feeding we just discussed. But to shatter that soundproof glass, standard speech therapy isn't enough. The absolute game changer is AAC.
Augmentative and alternative communication.
AAC encompasses a broad spectrum of tools designed to bypass or support spoken language. On the low-tech end of the spectrum, you have manual signing, like keyword sign, where you teach the child simplified hand gestures for core words.
Or you use simple laminated picture boards where a child can point to a symbol for hungry, thirsty, or pain.
But pointing requires fine motor control, which we know is compromised. So on the high-tech end, you have dynamic touchscreen devices, like dedicated iPads with specialized software.
And for a child whose hypotonia is so severe they can't reliably isolate a finger to point at a screen, technology has provided eye gaze tracking.
Eye gaze technology is a marvel for this population. An infrared camera mounted on the tablet bounces light off the child's pupils, calculating the exact angle of their gaze. The camera tracks where their eyes are looking on the screen.
If they stare at the icon for water for half a second, the computer selects it, and the synthesized voice speaks the word out loud.
The cognitive leap required for a child to realize, if I look at this glowing box, the machine will speak my thoughts and my mother will bring me water. That is a profound moment of agency.
The clinical consensus is that the implementation of AAC must happen as early as possible.
If a clinician knows a child has high receptive understanding, but a severe physiological barrier to speech, withholding an AAC device is ethically akin to withholding a wheelchair from a child who cannot walk because you are waiting to see if they will eventually walk on their own.
It is a fundamental tool for human connection. And human connection is what these kids crave. The patient registries overwhelmingly describe individuals with PURA syndrome as remarkably happy, loving, social, and deeply affectionate. They want to connect with their family.
They absolutely do. And a lack of communication is agonizing. Frustration, which often manifests in nonverbal children as severe behavioral issues, meltdowns, or even self-injury like biting their own hand.
Which frequently drops significantly once a child is finally given a reliable way to communicate.
Progress in PURA syndrome isn't measured in spoken vocabulary lists. It's measured in micro-victories. It's a new intentional vocalization. It's consistent eye contact with a communication partner.
Or it's that monumental moment a child first uses a picture board to tell you they have a stomach ache, rather than just crying inconsolably for hours. That is profound, life-altering progress.
It's giving them the keys to unlock their own mind.
But even as families and therapists are working tirelessly day in and day out to build these pathways, to improve the grasping, the feeding, the communication, the underlying genetic dysfunction often introduces a new, highly disruptive and dangerous element into the mix.
While therapies bridge the developmental gaps, the electrical activity of the brain itself begins to destabilize.
This typically becomes apparent in early childhood, most often between the ages of 2 and 5. The missing pure alpha protein causes a fundamental instability in how neurons manage electrical charges, leading to neurological storms.
The clinical data indicates that epilepsy affects over 50% of patients with PURA syndrome.
And we need to be clear, this isn't a mild occasional seizure that is easily controlled. The literature describes it as complex, evolving, and frequently refractory, meaning it is highly resistant to standard anti-seizure medications.
The epilepsy profile in PURA syndrome is notorious among pediatric neurologists for being difficult to manage. It rarely stays static. It evolves as the child's brain grows. A child might begin having what are called myoclonic jerks.
Let's explain the physiology of that. What exactly is happening during a myoclonic jerk?
Myo refers to muscle, and clonic refers to a rapid spasm. It is a sudden, brief, involuntary twitch or jerk of a muscle or a group of muscles.
It's caused by a sudden burst of abnormal electrical activity in the motor cortex of the brain, sending a rapid-fire signal down the spine.
It looks similar to that sudden, startling jerk you sometimes experience just as you are falling asleep. But for a child with PURA, these happen repeatedly while they are fully awake.
And as the brain matures, the seizures can generalize and progress.
Unfortunately, yes. The electrical storms can spread across the entire brain, progressing to generalized tonic-clonic seizures.
These involve a complete loss of consciousness, a rigid stiffening of the body, the tonic phase followed by violent rhythmic muscle contractions, the clonic phase.
In some of the most severe cases documented, the epilepsy evolves into Lennox-Gastaut syndrome.
Lennox-Gastaut is a devastating diagnosis. It's a highly severe form of childhood-onset epilepsy, characterized by multiple different types of seizures happening daily, highly specific abnormal brainwave patterns on an EEG, and tragically cognitive regression.
The seizures become so frequent and the electrical interference in the brain becomes so constant that the child actually begins to lose the developmental milestones, the fine motor skills, and the communication abilities they've fought so incredibly hard in therapy to gain.
The electrical storm washes away the pathways.
Which is why aggressive, proactive management by a pediatric epileptologist is mandatory. But because the PURA mutation affects every single neuron in the brain, surgical options like a focal resection, where a surgeon removes a small piece of seizing brain tissue, aren't applicable.
The storm isn't coming from one spot, it's everywhere. And to complicate the neurologist's job even further, not every abnormal movement a child with PRA makes is actually a seizure.
The literature points out a wide spectrum of non-epileptic movement disorders that are deeply intertwined with the syndrome.
You see dystonia, where muscles contract uncontrollably, causing the child's limbs or trunk to twist into repetitive, often painful postures.
You see dyskinesia, which are involuntary, erratic, writhing movements. And you see stereotypes, which are rhythmic, repetitive, seemingly purposeless movements like intense hand flapping, rocking, or hand biting.
A physician looking at a twisting child has to use continuous video EEG monitoring, recording the child on camera, while simultaneously measuring their brain waves to determine what they're looking at.
Is this twisting movement a seizure that demands a higher dose of anti-epileptic medication, or is it dystonia, which operates through a completely different pathway in the basal ganglia and requires a completely different class of medication to treat?
It requires immense precision from the medical team. And beyond the movement disorders, there is one specific non-epileptic reflex that stood out in the literature as a major diagnostic red flag: a highly exaggerated pathological startle response.
The medical term is hyperacusis, an extreme, massive reaction to sudden, unexpected noises or tactile touches.
If a door slams down the hall, or a dog suddenly barks, or someone unexpectedly taps their shoulder, a child with PRA syndrome might react with a massive, full-body spasm, throwing their arms out, that lasts far longer and is far more intense than a normal human flinch.
It's a reflection of an autonomic nervous system that is stuck in absolute overdrive, unable to filter out or dampen startling stimuli. The amygdala, the fear center of the brain, is overreacting.
The environment itself becomes an overwhelming sensory minefield.
It forces families to deeply modify their physical home environment, carefully managing acoustics, avoiding sudden loud toys, and constantly preparing the child verbally for any sensory changes before they happen.
But I want to pivot back to the seizures, because when standard anti-seizure medications fail, when the electrical storm just won't break, the sources detail a fascinating alternative approach.
The ketogenic diet case study.
Yes, there is a specific, deeply detailed case study of an 11-year-old girl with a PURA frameshift variant. She was suffering from daily refractory seizures that weren't responding to heavy pharmacological drugs like valproic acid.
She also suffered from severe sialorrhea.
Sialorrhea being chronic, excessive drooling, which is a very common secondary complication due to the facial hypotonia and swallowing difficulties we discussed earlier.
Right, so she's failing all these heavy medications. Her medical team decides to try a ketogenic diet.
And remarkably, within weeks, it not only significantly improved her drug-resistant seizures, but it also completely resolved her severe drooling, a dual benefit that had never been reported before in the clinical literature for PURA syndrome.
It is a remarkable case study.
I have to stop and dig into this. Wait, diet can stop seizures and drooling when heavy medications fail. How does changing what a child eats fundamentally rewrite the electrical activity in a brain missing a crucial regulatory protein?
Well, it forces us to look beyond neurotransmitter receptors and examine the foundational metabolic pathways of the brain. A classic, medically supervised ketogenic diet is extremely high in fat. Often 80 to 90% of calories come from fat, and very, very low in carbohydrates.
When you drastically reduce carbohydrates, the body quickly runs out of glucose. Glucose is the brain's default preferred fuel source.
So the body enters a state of perceived starvation. To survive, the liver initiates a backup metabolic pathway. It starts breaking down dietary fats into molecules called ketone bodies.
These ketones are released into the bloodstream, cross the blood-brain barrier, and become the new primary fuel source for the brain.
Okay, so we switch the brain's fuel from unleaded gasoline to diesel. But how does changing the fuel stop a neuron from misfiring and causing a seizure?
The exact molecular mechanisms are still the subject of intense neurological research, but we know that burning ketones alters the fundamental chemistry and electrical gradient of neurons. Ketone metabolism appears to significantly increase the production of GABA.
GABA is the brain's primary inhibitory neurotransmitter. If glutamate is the gas pedal for electrical activity, GABA is the heavy brake pedal.
So the diet forces the brain to manufacture more of its own chemical brakes.
It does. Furthermore, the presence of ketones seems to directly open specific potassium ion channels on the neuron's membrane. This hyperpolarizes the neuron, meaning it increases the negative electrical charge inside the cell compared to the outside.
A hyperpolarized neuron requires a much stronger stimulus to fire. It is physically harder for the neuron to trigger an action potential.
It raises the threshold for an electrical storm. So in a brain where PUR alpha is missing and the neurons are chaotic and hyperexcitable, the ketones basically flood the system with chemical breaks and raise the electrical barrier, calming the entire network.
When pharmacological route standard drugs hit a wall because they are targeting specific receptors that might be genetically dysregulated, changing the entire metabolic environment of the brain can sometimes bypass the genetic roadblock entirely.
As for the surprising reduction in coelurea, the authors of the study hypothesized that the diet might have modulated the autonomic nervous system's control over the salivary glands, slowing production.
Alternatively, the massive reduction in the seizure burden simply freed up enough neurological bandwidth for her brain to better control her resting oromotor tone and manage her own swallowing.
It's a powerful reminder that altering the metabolic landscape can stabilize a system that genetics has destabilized.
It's an incredible intersection of diet and neurology. But the brain isn't the only system destabilized by this genetic typo. We've been hyper-focused on neurology, but as we discussed at the beginning, the pure alpha protein is expressed in tissues all over the body.
That brings us to the broader physiological reality. Managing PURA syndrome is a full-body endeavor.
And often, it requires major surgical interventions to prevent catastrophic structural failures. And for these kids, surgery comes with its own terrifying set of unique risks.
To understand the full-body impact, we have to look at the mechanical wear and tear on the body over time. We keep coming back to hypertonia because it is the root cause of so many profound secondary complications. Chronic hypotonia leads to severe cumulative skeletal stress.
We have to talk about the physical relationship between muscle and bone. There's a principle in anatomy known as Wolff's Law, right?
Yes, Wolff's Law states that bone in a healthy person will adapt to the loads under which it is placed. If loading on a particular bone increases, the bone will remodel itself over time to become denser and stronger to resist that loading.
And the way it does this is fascinating. When a healthy, tight muscle contracts and pulls against a bone, it creates a microscopic amount of mechanical stress.
But that physical stress actually generates a tiny electrical charge in the bone tissue, a piezoelectric effect. That electrical charge is the signal that tells the body's bone-building cells, the osteoblasts, to lay down more calcium.
But in PURA syndrome, because of the profound central hypotonia, the muscles aren't providing that continuous, forceful pull.
The bone is never getting that electrical signal. So the body assumes it doesn't need to build dense bone. Without the strong muscular scaffolding pulling evenly on the skeletal frame, gravity simply wins. The bones don't grow straight, and they don't grow dense.
The clinical numbers on this are stark. 48% of individuals with PURA syndrome develop scoliosis, which is a severe lateral curvature of the spine. The sources detailed a harrowing case study of a 15-year-old Polish girl with PURA syndrome who required extensive spinal fusion surgery.
Her scoliosis had become so advanced that the curvature of her spine was physically compressing her thoracic cavity. The spine curves, and as it twists, the ribcage collapses inward, which eventually threatens to crush the lungs and restrict the heart from beating properly.
The surgeons had to go in, physically straighten the spine, and bolt long titanium rods to the vertebrae with pedicle screws to act as an artificial skeleton, forcing the spine to remain upright.
A massive traumatic surgery. And the hips are equally vulnerable to this lack of muscular support. They suffer from high rates of hip dysplasia.
The hip is a ball and socket joint. The head of the femur sits in the acetabulum of the pelvis. But the socket only develops its deep cup-like shape during childhood if the strong gluteal and leg muscles are constantly pulling the femur securely into the socket as the child walks and bears weight.
In a non-ambulatory child with hypotonia, the socket stays shallow. Eventually, the hip joint simply subluxates, slips out of place, or dislocates entirely, requiring complex orthopedic reconstruction.
And on top of the structural alignment issues, the physical bones themselves are incredibly weak. Osteopenia, or significantly low bone density, is widely reported.
This is often exacerbated by poor diet, low vitamin D levels from a lack of outdoor mobility, and the calcium leaching side effects of many long-term anti-epileptic drugs.
They are highly prone to pathological fractures. That means breaking a bone doing a normal, everyday activity like being transferred from a wheelchair to a bed that shouldn't generate enough force to cause a break in a healthy skeleton.
It demands constant, vigilant monitoring from an orthopedic team.
But the muscular issues extend far beyond the skeleton. The eyes are almost always affected.
Vision relies on 6 tiny extraocular muscles perfectly coordinating to move the eyeball. In PURA syndrome, those muscles are hypotonic. Strabismus, commonly known as crossed eyes or wandering eyes, is incredibly common, requiring surgical correction to prevent the brain from permanently suppressing vision in the weaker eye.
The sources also point to deep disruptions in the endocrine system. The pituitary gland, the master hormone regulator of the body, sits right at the base of the brain. The clinical data shows a growing link between PRA and anterior pituitary dysfunction.
The hypothalamus and pituitary gland rely heavily on pure alpha for development. When they are dysfunctional, the cascading hormone signals fail. This causes abnormal growth patterns. Some children fail to grow, requiring human growth hormone injections.
It also causes severe issues with puberty. Some experience precocious puberty, entering physical maturation at an unusually early age, while others are vastly delayed.
And we absolutely cannot forget the gastrointestinal system. Chronic severe constipation is a near-universal struggle for these patients.
Which, again, traces directly back to hypotonia. The intestines are lined with smooth muscle. If the central nervous system is failing to maintain muscle tone, the intestines struggle to perform peristalsis, the rhythmic, wave-like squeezing action that constantly moves waste material through the miles of the gut.
Combine a sluggish intestinal tract with a wheelchair-bound lifestyle lacking the gravity assist of walking, and poor fluid intake due to the dysphagia we discussed, and the GI system essentially grinds to a painful halt, requiring daily medical management.
So when you look at the whole patient, you have an individual who might require a G-tube placed in their stomach for feeding, might need delicate eye surgery for strabismus, and very likely will need major traumatic orthopedic surgery to fuse their spine or reconstruct their dislocated hips.
But here's the terrifying catch that keeps parents awake at night. Putting a child with PURA syndrome under general anesthesia to perform any of these necessary surgeries is highly, profoundly dangerous.
It's like fixing a house where the foundation is constantly shifting. You want to fix the spine, the frame, but the process of putting them to sleep to do it threatens the ventilation system. How do medical teams balance this?
This raises an important question about multidisciplinary care. It is considered an orphan anesthesia risk. The guidelines compiled by the Orphan Anesthesia Network, a global initiative for rare diseases, are incredibly strict and stark for this specific population.
No single physician can manage a PURA patient in an operating room safely. Think about the mechanism of anesthesia. When an anesthesiologist induces a patient, they are intentionally administering neurotoxins to temporarily suppress the central nervous system.
But in a child with PORA, their central nervous system is already operating at a deficit, barely struggling to maintain baseline breathing and airway tone. They are exquisitely hypersensitive to respiratory depressants.
The guidelines state clearly that anesthesiologists must reduce the standard induction dose of opioids and benzodiazepines by a full 50%, half the normal dose.
Because if you give them the standard amount calculated for their body weight, their brainstem simply will not boot back up to tell the lungs to breathe when the surgery is over.
Furthermore, they suffer from the autonomic dysregulation we saw in infancy. They cannot control their own body temperature under anesthesia. A cold operating room can send them into dangerous hypothermia.
The surgical team must use active thermoregulation forced air warming blankets and IV fluid warmers to carefully maintain core temperature.
And as they wake up in the recovery room, that floppy airway, the obstructive apnea we talked about in newborns, becomes a massive, immediate risk all over again as the breathing tube is removed.
As the endotracheal tube comes out, the drug-induced hypotonia can cause the pharynx to instantly collapse. The anesthesia guidelines strongly recommend the prophylactic, preventative use of a nasopharyngeal airway.
This is a soft, flexible silicone tube placed through the nose, extending down past the soft palate into the throat to physically stent the airway open while the child slowly metabolizes the drugs and regains their baseline muscle tone.
And because of all these compounding risks, the guidelines make it clear. There is no such thing as day surgery or outpatient procedures for a child with PURA syndrome.
None. Even for minor procedures, the guidelines mandate a strict minimum of 24-hour inpatient apnea monitoring postoperatively. The risk of delayed respiratory failure as the drugs slowly leave the fat tissue is simply too high.
Performing surgery on these children requires a perfectly synchronized symphony of specialists. The orthopedic surgeon operating, the neurologist adjusting the seizure meds around the fasting period, the pulmonologist assessing lung capacity, and a highly specialized pediatric anesthesiologist managing the chemical tightrope.
It is a monumental, exhausting undertaking for the medical team and an unimaginably stressful, terrifying event for the parents waiting out in the surgical waiting room. Which leads us to the final horizon of our deep dive today.
With such a complex, full-body presentation that mimics so many other disorders, we mentioned it looks like SMA, it shares traits with Prader-Willi syndrome or Rett syndrome, just getting the correct diagnosis in the first place is half the battle.
In the rare disease community, it is universally referred to as the diagnostic odyssey. Families often spend years, sometimes over a decade, traveling from specialist to specialist, enduring painful muscle biopsies, running single-gene tests that come back negative, and living in an agonizing state of diagnostic purgatory.
But the landscape of diagnosis is rapidly changing, largely due to the sheer computing power now available to geneticists. Diagnosis today relies heavily on whole exome sequencing, or WES, and chromosomal microarray, CMA.
Instead of guessing which gene might be broken and testing them one by one, whole exome sequencing looks at the entire protein coding region of the patient's genetic code all at once.
It scans the millions of base pairs of DNA, specifically hunting for that single typo, that single deleted phenylalanine.
And when a family finally gets that phone call, when they finally have that piece of paper with PURA syndrome printed on it, it unlocks so much. It ends the agonizing search. It guides the specific therapies like prioritizing AAC and guarding against anesthesia risks.
And importantly, it provides accurate genetic counseling and recurrence risk for the parents. Because this is almost always a de novo, spontaneous mutation, geneticists can sit down with parents and assure them that the risk of having a second child with PURA syndrome is extremely low, generally cited as less than 1%.
Less than 1%. Though the medical literature does mention a rare biological caveat called germline mosaicism. We should explain what that actually means.
Germline mosaicism is a fascinating biological phenomenon. It means that while the parents' blood tests show they are perfectly healthy and don't carry the PURA mutation in their bloodstream or their skin, a small, isolated cluster of their reproductive cells, the germline, meaning either the sperm or the eggs mutated during their own fetal development. The parent is essentially a genetic patchwork.
So a small percentage of the eggs or sperm carry the broken PURA gene, even though the parent doesn't have the disease.
Exactly. Because of the slight chance of germline mosaicism, the recurrence risk is slightly higher than the general population's baseline, but it still remains very, very low.
So once a family survives the neonatal period, pushes through the therapies, and finally has the definitive diagnosis in hand, the inevitable, heavy question every parent asks the neurologist is, what does the future hold? What happens as my child grows out of pediatrics and becomes an adult?
The single most important, hopeful fact to establish early on is that PURA syndrome is not a degenerative disease.
That is a huge, critical distinction.
It is paramount for a parent's mental health to hear that. Unless they suffer a catastrophic structural regression due to uncontrolled, severe Lennox-Gastaut seizures, these individuals do not slowly lose the skills they acquire. Their brain tissue is not dying off like an Alzheimer's or Huntington's. They make progress.
It is agonizingly slow. It requires massive daily therapeutic intervention, but they move forward. They survive into adulthood. The patient foundations know of diagnosed patients currently living in their 30s, 40s, and even 50s.
But the reality is they will require 247 lifelong care. They will remain dependent on caregivers for their basic activities of daily living, feeding, dressing, hygiene, and mobility. And the clinical guidelines heavily stress that transition planning for adulthood cannot wait until they turn 18. It must start early, usually recommended by age 12.
Because the safety net of pediatric care suddenly vanishes. Families have to navigate complex legal systems to establish guardianship so they can continue to make medical decisions. They have to transition from a single pediatrician to a fragmented network of adult specialists who often have absolutely no idea what PURA syndrome is.
And they have to find adult D programs that are actually equipped, staffed, and funded to handle nonverbal individuals with complex medical needs.
And as they enter their teenage years, new, hormonally driven challenges emerge. The sources note behavioral challenges like severe anxiety become prominent, often triggered by sensory overload as their environments become more complex. You also see an uptick in self-injury stemming from the sheer frustration of that enduring communication barrier.
Which underscores exactly why early AAC implementation is so utterly critical. If a child has built a robust method to express their voice by the time they are teenagers experiencing these immense internal changes, the behavioral frustration and anxiety are significantly mitigated. They can tell you they are overwhelmed before they have a meltdown.
So that is the clinical day-to-day reality of growing up and living with PURA syndrome. But what is the scientific community doing about it? Because the timeline of research here is moving incredibly fast.
It is moving at an unprecedented breakneck pace for a rare disease. And the driving force isn't coming from massive pharmaceutical companies, it is being driven directly by the families. The global patient advocacy groups, primarily the PURA Syndrome Foundation and the PURA Foundation Australia, have aggressively organized to create a global patient registry and an international biobank.
They are meticulously collecting longitudinal natural history data tracking exactly how the disease progresses over decades, and they are collecting physical tissue samples, blood, and skin fibroblasts from patients all over the world, storing them centrally for researchers.
And this organized parental effort has catalyzed a massive leap in preclinical research. In May 2025, a landmark multi-million-dollar collaboration was announced between the Jackson Laboratory, known as JAX, one of the premier genetics labs in the world, and a nonprofit called JAX Tomorrow. They utilized CRISPR-Cas9 gene editing technology to successfully create what is called a knockout mouse model.
To explain how monumental this is, we have to look at how CRISPR works. CRISPR utilizes a guide RNA that is programmed to find the exact genetic sequence on the 5q31.3 locus. Once it finds it, the Cas9 enzyme acts as molecular scissors. The researchers literally went into a single-cell mouse embryo, used CRISPR to intentionally cut out a specific portion of one PURA allele, mimicking the exact genetic deletion seen in human patients.
And the resulting genetically engineered mouse exhibits the exact foundational features of the human syndrome. The mice suffer from severe motor deficits, profound hypotonia, and fatal seizures.
Now, a listener might ask, why is creating a sick, dying mouse considered good news for patients? It sounds counterintuitive.
Because the FDA and international regulatory agencies demand proof. You absolutely cannot test a novel, highly experimental gene therapy, like a viral vector, delivering a healthy PURA gene into the brain on a human child without first proving it is safe and actually works in a validated biological model. The knockout mouse is the proving ground. In parallel, brilliant researchers at the Florey Institute in Australia are now utilizing these mice alongside the human stem cell lines from the biobank to aggressively test plausible mechanisms for gene-based therapy.
Okay, realistically, we have an ultra-rare disease with maybe 800 people diagnosed globally.
Yeah.
Usually, pharmaceutical companies ignore numbers that small. Why is there suddenly so much high-tech momentum for PURA?
The organized patient advocacy groups building those biobanks and registries completely de-risk the early, most expensive stages of research for scientists. The researchers don't have to spend 5 years and millions of grant dollars trying to locate patients, establish baselines, and collect tissue samples. The families, organized on Facebook and at conferences, hand the raw data and the biology to the scientists on a silver platter.
The parents say, here are our children's cells, here's our 10-year natural history data, the groundwork is done. Please just start experimenting and help us.
Precisely that. And secondly, regulatory agencies like the FDA have finally recognized that the old blockbuster drug model doesn't work for ultra-rare diseases. They are currently creating quicker, specialized regulatory pathways specifically for individualized, bespoke gene therapies. If researchers at the Florey Institute can prove a plausible mechanism of action, if they can show that delivering a gene fixes the neurons in a petri dish and cures the seizures in the validated JAX knockout mouse, the FDA is opening legal doors to move those treatments into human safety trials much, much faster than a traditional pharmaceutical drug.
It is an absolute revolution led entirely by desperate, relentless parents refusing to accept the status quo. They are literally rewriting the future of this disease. Which brings us to the end of our incredibly extensive deep dive today. We have covered a staggering amount of biological and emotional ground. We started by looking at a tiny microscopic genetic deletion, a single exon gene missing a single phenylalanine building block, and traced how the absence of that crucial project manager protein, PUR alpha, derails the construction of the developing brain.
We walked through the terrifying neonatal crisis of the floppy baby, the central apnea, and the dysphagia. We looked at the immense daily hurdles of gross and fine motor delays and explored the biomechanics of how specialized occupational therapy can help a child achieve the monumental cognitive and physical task of grasping a weighted spoon to feed themselves.
We explored the silent, frustrating world of the receptive-expressive gap and how high-tech AAC eye gaze devices provide a vital, life-altering bridge to a brilliant mind trapped behind a physical barrier. We discussed the electrical storms of refractory epilepsy, the surprising metabolic power of the ketogenic diet to flood the brain with GABA, and the terrifying full-body structural risks of scoliosis and orphan anesthesia.
And we ended looking at the horizon, seeing how an organized, relentless global community of a few hundred families is utilizing CRISPR mouse models and new FDA pathways to force the scientific world to pay attention.
To the listener out there, whether you are a parent currently fighting with your insurance company to get an eye gaze AC device funded, or an exhausted caregiver trying to navigate the anxiety of an upcoming orthopedic spinal fusion surgery, we want you to know this. You are not alone in the murky waters. You are part of a newly connected global community that is actively, aggressively pushing science forward.
And as we close today's deep dive, there is one final, truly mind-bending connection that we found buried deep in the molecular research that reframes this entire condition. We mentioned early on that pure alpha is a master regulator that transports mRNA and controls gene expression.
Right, the highest level project manager in the cell.
Well, researchers looking closely at the structure of pure alpha have recently discovered that this exact protein interacts directly with the specific genetic repeat expansions, the toxic molecular aggregates that cause amyotrophic lateral sclerosis, ALS, commonly known as Lou Gehrig's disease. Furthermore, it interacts directly with the specific genes that cause frontotemporal dementia and Fragile X syndrome.
ALS dementia. We are talking about massive neurodegenerative diseases that affect millions of people worldwide, diseases that have completely baffled the brightest scientific minds for decades.
The underlying foundational biology of pure alpha is intimately, deeply entangled with the biology of these massive neurodegenerative giants.
Could the key to finally curing some of the world's most devastating, widespread neurological diseases be hiding inside the exact biology of this ultra-rare, one-in-a-million pediatric condition? Could the answers to ALS and dementia be unlocked by studying the children fighting PURA syndrome? It's an incredible, profound thought. Keep digging and keep learning.